Hi everyone, thanks for all of you who gave me some positive feedback about my grand round last week and those who asked for more regular updates. My intention is to try and weekly give you an update of what's new in the literature, anything that changes our clinical practice, and basically to try and keep you as informed as possible so you can make your own judgments. Obviously I have my own opinions, which I will give, but I really very much want to make sure that all the clinicians have all the data that I've seen and I'm aware of so you can make your own judgments as well. Just in terms of my conflicts, I have picked up a advisory for a company that's got an experimental SARS drug. I'm not mentioning it in this talk, but just so you're aware. Okay, so we do seem to be at war, everyone says, with the COVID or SARS-CoV-2 virus. I think, again, as I said last week, it's appropriate to be concerned and to have precautions in place, and all the planning we're doing is absolutely appropriate. But the level of fear and panic, I think, is completely unjustified by the literature, and I just want to go through just a little bit of data about that for you. So if we look at this table of mortality by volume and country, yes, in Italy it's been an absolute disaster. Now, case fatality rate of 11.43%, every single case fatality rate is going to reduce as we become aware of more and more asymptomatic cases in the community. But Italy really is a standout. As you go down that list and you come to countries like the UK, 4.94%, but then we keep going down. And if you march down, for example, to the USA, which has had 35,000 cases, it's only reporting a mortality rate of 1.31%. South Korea, 1.24%, and then Germany, which has had more than 26,000 cases, reporting 0.42% mortality. Now, I've included Australia and Norway there because they are down the bottom of the table, but they're not fair comparisons yet because we haven't yet got SARS-CoV-2 circulating in at-risk populations. But you have to ask, why is there such a big difference in mortality? And I know that last week I showed this graph of the fact that the very high mortality reported in Wuhan, and as it progressively went on, the mortality dropping, and there was a suggestion that maybe this is change in virulence of the pathogen. But in fact, with the Italian data and some of the other countries, I think that what time will show is this is excess mortality due to failure of a health system. These health systems, including Italy, were caught unprepared. They had masses of patients flooding their system. They lost key doctors and nurses, not necessarily from mortality, but just becoming ill. So then you have compounded the problem of not having enough experienced people on the ground with lots of sick people, and you get excess mortality. And I think that we are well prepared. We are as well trained as anybody in the world. I would be expecting us to have mortality rates equivalent to Germany, not to Italy. And that's why this graph that occurred in the Australian the other day is so important in terms of the current social distancing and measures that are being taken, is we really do not want to be at the top of this logarithmic curve here. We want it to flatten out. We don't want to get to the 10,000 and certainly hundreds of thousands of cases, because then we would be in a failing health system, and that's when I think we would get all that excess mortality. So I'm fully behind everything that's being done as far as that. What's the latest on who's dying? As you can see, very much as I showed last week, very few deaths in young people. There are cases certainly coming out of Spain, and I'm working quite closely with two groups in Spain of young kids presenting with very much what looks like RSV bronchiolitis, but is coronavirus. And as you can see, the mortality really drastically upscaling above 60. And again, comorbidities, if you've got those comorbidities, substantial increased risk of death. Now, what is important, of course, and because that's driving a lot of concern, is what about healthcare workers? And I need to say that at the moment, there is absolutely no evidence that healthcare workers are having any different outcomes to what's being reported for everybody. Now, yes, there are some higher rates of infection in healthcare workers when they're not using PPV or when that protective gear has run out, like in Italy and Spain and Wuhan. But the evidence is that standard PPV works incredibly well and that if you do get that coronavirus, you're going to have the same mortality as everybody else, which in most of our healthcare workers is exceptionally low. So SARS-CoV-2 is not SARS and it's not MERS. It's serious, yes, but again, there's not a reason to be panicking. What about the immunosuppressed? So far, we're actually not seeing particular concerns. They're not being reported as having bad outcomes, but the total number of cases reported is low, so I think we still need to take some sensible precautions. The presentation may be atypical in immunocompromised patients, and there is a report, for example, that patients with renal transplants are tending to present with diarrhoea and GIT symptoms rather than respiratory symptoms, so we just need to be aware of that. I was asked a lot of questions about what is the ICU mortality looking like outside of China. So in Barcelona, with one of the large hospitals there I'm working with, out of their first 48 cases, mortality is 18%. If you compare that to Wuhan, which was reporting 16%, clearly in ICUs that are more equivalent to ours, in health systems that have not yet been overtaxed, it's certainly not a hopeless disease. So sensible precautions, follow the guidelines, and make sure others follow the guidelines. And if you want to give yourself a little bit of a wake up, there's a really nice article on how many viruses you can find on your mobile phones that you're wandering around work with that might make you rethink exactly what you're doing at work. So I think there are some new insights into pathogenesis and the clinical syndrome of SARS-CoV-2. This table comes from a paper we have coming out. And it's based on Spanish data, not Chinese data. The type 1, which is most of your symptomatic patients, really a mild viral ERT, normal chest X-ray, excellent prognosis. Around 80% of hospitalised patients present with mild hypoxemia, basically a mild viral pneumonia. About 85% or so do well. About 15% will progress to a type 3. Type 3 is either a progression from 2 or patients may present that way. That's significantly more hypoxemia, basically a significantly worse viral pneumonia, very high inflammatory markers, and a relatively high risk of progressing to type 4 or 5. And the big difference between my presentation this week and last week is that the Spanish and also the Italians and to some extent Americans that have started to see this is the majority of those going to ICU needing mechanical ventilation are not an ARDS phenotype. Only about 20 to 25% are an ARDS phenotype. That's what we're calling type 5. They have high procalcitonin and need all the standard ARDS type management. But type 4 is severe respiratory failure, but when you ventilate them, they have normal compliance. And they tend to respond exceptionally well to nitric oxide. And so I think that's very important in terms of what we may anticipate. The big messages: don't delay mechanical ventilation in those in whom you're not withholding ICU, because high flow oxygen won't cut it and may worsen the outcome if you delay. Don't use NIV with SARS-CoV-2 pneumonia because it doesn't work and it does increase cross-infection risk, and nitric oxide is a key component of mechanical ventilation strategy. In terms of diagnosis, a couple of things to cover. Look, while we all wish we had Mr. Spock's tricorder, and I'd love to diagnose someone with cerulean fever, we don't have that yet, but we do have platforms like this. This is the Gene Expert by Kefford. There are many competitors in the market, but Kefford announced 2 days ago that their platform, which currently is essentially within an hour turnaround time for influenza and RSV with excellent performance characteristics, they now will add SARS. They've got approval to add SARS-CoV-2, and that should roll out relatively quickly. That means that instead of having to wait days, we should be able to realistically get an answer back within an hour, and it's really about transport time. And these types of technology, conservatism from clinicians, but particularly from laboratory microbiology, has really held back application of this kind of technology, and I hope that this actually will break the dam and we will all start to expect more from point of care technology. Probably what everyone needs to be aware of is the increasing realisation that the false negative PCR, particularly in sick patients. There are many case reports. It's reported as being quite common by clinicians on the ground. 2 radiology papers, one that's published suggested a 34% false negative rate if you use CT as a gold standard. I've seen an additional paper in press that's suggested 40%. There are questions of whether a CT scan is an appropriate gold standard, but I think if you're in the middle of a pandemic, you've got 100 patients presenting a day with bilateral pneumonia, and you're seeing 40% of them, which look exactly the same as the others, having a negative PCR, you know you've got a problem. There's certainly going to be issues of the quality of sampling, the transport, possibly laboratory performance issues. There are difficulties getting samples off of sick patients. And we know that, and I'll show you some data in a second, that as the disease progresses, viral load drops off and sicker patients have had their illness much longer. So there are all kinds of reasons why the laboratory tests may not be perfect other than just a problem with the assay. But we need to know that the assay can be negative. This is a paper published yesterday and just shows very nicely with onset of, time of onset of symptoms here, that you can get a 4 log reduction in viral load over time. So perhaps not surprising that the sicker patients may prove negative. What are the implications of that? Look, if it looks like SARS-CoV-2 and the PCR is negative, you treat it as if it's SARS-CoV-2. From an infection control point of view, from a clinical point of view. Repeating the assay, if it's clinically relevant, might help. And immediately everyone's going to go, oh my God, what about all of the community cases that we're screening? Are they actually all positive when we're saying they're negative? I don't think that's likely. Firstly, viral loads are going to be highest in those patients. Getting quality samples off them is not as hard. And the people who are taking the samples are doing it all the time, so they've become highly skilled. And if it was a case of we were seeing lots of negatives in those, false negatives in those patients, I'd be expecting us to have a bigger hospital problem by now. So I'm not concerned about the community screening of the not particularly unwell, but it is a problem in the significantly unwell. Quick update on procalcitonin. While a data from Wuhan was suggesting it was helpful, it turns out that it's not particularly helpful prognostically, at least according to the Chinese and Europeans. However, we're starting to see lots of reports of co-infection with patients presenting with COVID-19 as well as pneumococcus, staph, even meningococcus, and those patients typically have a high PCT. While the case reports are in younger people, there's a paper that I've seen that suggests that it's even higher in elderly people. So we need to be aware of that, and I think procalcitonin is still useful on presentation. In terms of imaging, there's a lot of interest in ultrasound and in terms of its ease of infection control compared to chest x-rays, the need to not have to repeatedly irradiate patients, and data coming along that it's also useful prognostically and following patients, particularly in skilled hands. There's an awful lot of CT papers, but they're not actually showing changes in therapy based on them at the moment, so that's a place to watch. Finally, turning to treatment, the big issue last week, of course, was the publication of the HIV protease inhibitors published in the New England Journal. This was a randomised, open-label study where you had to be PCR positive and hypoxic, and that, I guess, will be the main criticism from people who still believe in the protease inhibitors, that if you gave it even earlier, maybe they wouldn't have become hypoxic. But essentially, in a reasonable number of patients, absolutely no difference in clinical outcomes, no difference in mortality, no difference in drug-related adverse effects. Post hoc, on a modified intention to treat, they think maybe patients were 1 day faster clinical improvement. I don't think that justifies the risk. What is key, as you'll see from this table in the manuscript, is that on average patients were around 13 days into symptoms before they started treatment. So again, would earlier treatment work? And as you can see, this is the graph of improvement rates, really nothing spectacular for the protease inhibitors. Now, if you go to clinicaltrials.gov, what you'll see is there's 119 studies listed at the moment for SARS-CoV-2, 104 active or completed, 8 trials of chloroquine or hydroxychloroquine, 11 randomised controlled trials of HIV protease inhibitors, 7 RCTs of alpha interferon. So, for researchers wanting to make their mark, I would strongly suggest that anyone in Australia is not really going to make much of an impact with our studies with those going on. Lots of other experimental agents, which I'm really just showing you to show you the level of interest and the sheer amount of work that's being done in this space, which offers us quite a lot of hope of being much better off knowing what works and what doesn't work, and developing new therapies over the next 3 to 4 months. And I think also of interest, stuff like mesenchymal stem cells, for example, where there's quite a significant number of trials, and even 3 vaccine trials already up and running. So overall, don't panic. Yes, it's appropriate to be concerned. Yes, we need to take appropriate precautions. Yes, you need to use the appropriate personal protection and make sure everyone else is doing the right thing. But overall, I don't see the data as something that needs us to be running around, panicking, or being overly concerned about, drastic healthcare outcomes, because I think that we are in such a better place than Wuhan was, or for example, Italy was or is. And I will give another update next week. Thank you.